Good afternoon, everyone. My name is Dr. Dominic Akatiba, and I'm with Ghana Medical Help. Thank you so much for joining us this afternoon for our Maternity Service Agenda webinar. This week, we are looking at diabetes in pregnancy. This would be led by Dr. Harriet Morgan. Dr. Morgan is a physician specialist with over 15 years of medical expertise. She specializes in internal medicine and with a focus in diabetes and obesity care. She holds a postgraduate membership with the West African College of Physicians and the Ghana College of Physicians and Surgeons, what we colloquially call double specialists. She earned a Master of Science with distinction in endocrinology and diabetes from the Queen Mary University of London. She's completed a clinical fellowship at the Leicester Diabetes Center in the UK, and she trained in advanced diabetes technology, including the continuous glucose monitoring and the insulin pump therapy. Her clinical expertise include managing adult patients with diabetes, diabetes in pregnancy, and it's not surprising that she's leading us today in that all-important topic, and also early onset diabetes as well as complex obesity. She's actively involved in research and has presented her work at national and international conferences, contributing to global best practices in diabetes care. So today we are really glad and happy that Dr. Morgan has made some time to join us. We are privileged to have you, Dr. Morgan. Like you may have noticed, and a few other settings I would be doing, once Dr. Morgan starts her presentation, you'll be unable to unmute yourself. This is to prevent people from inadvertently unmuting themselves. However, the chat box is open. Kindly put in your comments, questions in there throughout the presentation. But at the end of her presentation, we'll allow you to be able to unmute yourself to ask a question or make a contribution. So once again, thanks a lot for joining us, and kindly join me in welcoming Dr. Harriet Morgan. Dr. Morgan, your audience.
Thank you very much, Dr. Akatiba, for the very kind introduction. And I'm actually very glad to share this afternoon with you on the topic diabetes in pregnancy. I hope that we're all able to learn something from today's presentation that helps us to improve our practice. All right.
Dr. Morgan, if you could kindly speak up a bit, the microphone seems on the lower side. Yeah.
Can you hear me now?
Yeah, it's loud and clear now. Please go ahead.
Okay.
Thank you.
All right. Okay. So yeah, I was saying thank you for your kind introduction, and we'll be discussing diabetes in pregnancy today. I hope that I will be able to give you an overview of what this entails, how to manage a patient if you encounter one. And like Dr. Akatiba said, my name is Harriet Morgan, and I'm currently working at the Tema General Hospital. So before we start today's presentation, I just wanted us to do a short poll. So can you please put your answers in the chat box for me? So question 1, 2, 3, and 4. I just want a fair idea of what our understanding is. So can everyone just put a quick answer? So the first question is there a diabetes clinic in your facility? Yes or no? So just put A for yes, or you can just put yes and no there. And then number 2, is there a diabetes clinic specifically designed for pregnant women at your facilities? And then number 3, what is the criteria for diagnosing pre-existing diabetes in pregnancy? Is it A, FBS, B, RBS? What do you use at your place? C, HbA1c, or is it all? And 4 is there routine screening for gestational diabetes in your facility? So you can just put the answers in the chat box. Am I not seeing it, or people have not put anything?
Yeah, I think people are here to put anything in the chat box. Kindly put in your answers in the chat box. Just to alert you that no one would be able to see your name rather than the host. So please feel free.
This one is not even marked, just to get an understanding of everyone's. Dr. Cuthbert, did anybody put anything or there's still nothing? Okay, I can see someone said yes. Okay, I see one person has answered. Okay, can I see at least two more and then we can go on? All right, okay. So in the interest of time, I will continue. All right.
Are you able to see the
So this is
chat
going to
box?
be,
Are you able to see the
yes.
comments in the chat box? Okay, because I see about 5 people have put responses in there.
I just see one person's answer.
Oh, okay. So I think I could just read the others to you. I think Velda puts
Okay.
in one is yes, two is no. I think question one yes, two no, three
Okay.
all. Three is all, and then four
Yeah.
is no.
Four is
No.
no. Okay.
Yeah.
All
Then
right. Okay. Fine.
is it good or you want me to take the others?
Yeah, it's fine. Let's go on. It
All
was
right.
just to
Yeah, great.
see. All right. Okay. Um, so this is going to be the outline or the order of the presentation today. What is diabetes in pregnancy? What's the scale of the problem? What's the definition? How do you screen people for this? How do you make the diagnosis? How do you manage the patients antenatally? And then when they are in labor, how do you go about it? So I hope that at the end of the presentation, we'll be able to go through this and so diabetes mellitus, we know that it's one of the most commonly encountered pregnancy medical complications. There are several other medical complications that can occur in pregnancy. And I think we're all very aware about hypertension and preeclampsia, but diabetes, we don't really talk about it much. But actually, it's the most commonly encountered medical condition in pregnancy. And it has adverse perinatal outcomes if we don't manage this well. It can have implications for both the mother as well as the baby. And so it is important that we manage this very well. In a recent paper by Osei Japon et al., they found that the prevalence of diabetes in pregnancy was actually about 8%, with GDM accounting for 86% of cases. And I think this is a bit reflective of what happens. Like in the general population, we have lots more type 2 diabetes and less type 1 diabetes. And because GDM sort of mimics or is reflective of type 2 diabetes, it's not surprising that is what is very common. And another paper by Upon et al., this was 10 years ago in 2015, found the range for GDM prevalence to be between 10%. Generally, estimates have given this between 9 and 15% in Ghana. In the UK, where their data is actually very accurate and they collect information routinely on all pregnant women, they know that it affects about 10 to 20% of pregnancy. So it's not so different from what we have done here, but I think that we need more and more studies to be able to um, tell exactly what our prevalence is like. What is diabetes in pregnancy? So there are actually two definitions. One of these would be pre-existing diabetes. That is somebody who has type 1 diabetes or type 2 diabetes, who knows that they've got diabetes prior to getting pregnant. So already by the time you're meeting them for the first time in clinic, you already know that they have, if you ask them about their medical history, they'll tell you that, oh, I have diabetes, either type 1 or type 2. So that would be pre-existing diabetes. And then we have gestational diabetes, which is something which is incidentally or discovered in pregnancy. So if you go looking for it, this person previously did not have diabetes, but because she is pregnant, develops diabetes. And this typically happens between 24 to 28 weeks. That's so generally those are the two cases, either pre-existing diabetes in someone who has diabetes before, or gestational diabetes in someone who develops diabetes just for the mere fact that they are pregnant. And with pre-existing diabetes, there can be two scenarios. So either, like I said, the person knows that they have diabetes prior to getting pregnant, or you you incidentally discover this in pregnancy. And actually, that happens unless we are ill. And so, this population actually represents those who are undiagnosed. So, even though they have diabetes, they do not know that they have diabetes. And so, they don't seek care for it. But for the fact that they are pregnant and they get into contact with healthcare practitioners, at the first visit, you realize that their sugars are very high. And so, as I was explaining, those who are diagnosed before pregnancy or those who are discovered for the first time in pregnancy, but actually people with true GDM don't have diabetes at the time of at the time of conception. This diabetes only develops as the pregnancy goes on. And so, like I said, this person may have diabetes, but because they have not been to the hospital before, nobody checks, nobody knows. But once they get into contact with us, then we find that they have diabetes, but through just of pregnancy. And so, in an ideal world, if someone has pre-existing diabetes, that is, I know I have type 1 or type 2 diabetes, or I know that I've had diabetes in the past and I want to get pregnant, in an ideal world, they would come to the hospital, they would tell either the diabetes doctor or the obstetric doctor that, oh, I want to get pregnant. What shall I do? And this is the point where you go through to the diabetes. They may be on medications which would not be indicated in pregnancy. And so you would typically review their medications. We know that only metformin and insulin are the only recommended medications in pregnancy. So, for instance, if they're on DPP4 inhibitors like galvusmet, if they're on SGLT2 like dapagliflozin, if they are on, say, a GLP-1 injection, those medications would need to be stopped and switched to medications that are safe in pregnancy. So ideally, you'd want this person to come and then you can do this medication review. In addition, we know that people with diabetes may have renal impairments or may have hypertension and might be on ACE or ARBs. These medications are contraindicated in pregnancy. And so again, if you did a medication review, you would see that the patient is on these medications and you would advise them not to take it. Again, you would want to know what their baseline HbA1c is. For the people who have diabetes before you become pregnant, it is recommended that your HbA1c is less than 6.5%. And so if this person comes and maybe the HbA1c is 8% or 10%, you can advise her to hold on with the pregnancy so that you optimize her glucose levels prior to her getting pregnant. And you would also ensure that she's on folic acid supplementation. And in people who have diabetes, you need to make sure that they are taking this dose at 5 milligrams. And so, again, as I keep emphasizing, in an ideal situation, you want somebody who has diabetes prior to pregnancy, that this person actually visits the hospital and have that discussion with their doctor so that we can make sure that everything is in place before the pregnancy goes on. For people who have had previous GDM, they might need to be screened earlier in the pregnancy other than the normal recommended time. And so again, you'd want this person to let you know that they are planning a pregnancy so that if there's any investigations that you need to do at the beginning, you can set this. But unfortunately, this doesn't happen. Women just fall pregnant and show up. Very few pregnancies actually are planned. And so most women would accidentally discover that they are pregnant. And at that point, they would come to the hospital. According to WHO and the American Diabetes Association, that is not a hope lost. Because if you're meeting this person at booking, which ideally would be in the first trimester, there's still room for us to screen these patients. And so, who are the patients that you'd screen? You'd do the BMI, and anybody who is overweight i.e. BMI more than 25, you want to screen that person for diabetes at booking. If the person had previous gestational diabetes, as I earlier mentioned, you don't want to screen that person early. If the person tells you that, oh, my father, my brother, my sister has type 2 diabetes or has diabetes, you don't want to screen that person early. High risk ethnicity refers to, we know that people who are Black, people who are Indians, people who are from the Pacifics, we tend to have a high incidence of diabetes in our population. And so such a person should also be screened. If anybody has a history of cardiovascular disease, we know that hypertension, diabetes, cardiovascular disease, they are brothers and sisters. And so if someone tells you that, oh, I have a history of this, again, you want to screen this person at booking. If the person has polycystic ovary disease syndrome, we know that that is an insulin resistant state. And so you want to screen this person also for diabetes. So all these people at booking should be screened. And for those, you would screen them at booking to discover if they have pre-existing diabetes, because these people that I have mentioned are at an increased risk of diabetes. So you want to find out if they have diabetes at that point. However, for those who screen negative to all these questions, for those who screen positive, so my first question, what test can you do? We're going to use the regular cutoffs for diabetes in a non-pregnant adult population. And so if their fasting blood glucose is more than 7, if their HbA1c is more than 6.5, if their random blood glucose is more than 11, or if they do an OGTT and their 2-hour glucose is more than 7.8, then this person has pre-existing diabetes and should be managed as such. And so you diagnose this person as having pre-existing diabetes rather than gestational diabetes. So for those who screen negative for this, you still need to screen them. So every pregnant woman should be screened for diabetes at a point, either at booking or between 24 to 28 weeks, which is where gestational diabetes would happen. And we'll talk about how the screening is done further as we go along. But this is done with an OGTT using the 75-gram. We do that here in America. They do the two-step process where they do the 100 grams, but we will talk about it as we go on. And so if this person now comes to you and says that, oh, I have diabetes and is pregnant, immediately what should you do? You should review for the presence of complications. Could they have eye disease? We know retinopathy. And so if this person has not been screened in the past year, needs to be screened for retinopathy, because we know that retinopathy can worsen with the onset of pregnancy. And so you should send that person for an urgent screening. You also want to look at their kidney. We know that people can develop nephropathy. And so you want to make sure that they don't have a baseline nephropathy, because all these would increase their risk in pregnancy. You want to make sure that is the person on folic acid. If not, and they are still in the first trimester, you want to quickly put them on 5 milligrams of folic acid. And then you would explain to the patient that because you have pre-existing diabetes, to prevent your risk of preeclampsia, when you get to the end of your first trimester, we would need to put you on aspirin so that they are aware and they can have this conversation as the consultation. So as you're meeting them for the first time and you discover that they have pre-existing diabetes, these are the things that you would want to go through. And yeah, so this is the booking sheets which we use at our facility, which you would fill out the forms and make sure that you explain to the patient what is going to happen. But if the person doesn't have pre-existing diabetes, then we're going to screen for gestational diabetes. And what is gestational diabetes? It's diabetes that occurs as a result of the pregnancy. So because the person is pregnant, their blood glucose levels rise. And we know that, as I've explained, this typically happens as the pregnancy progresses, with the peak insulin resistance happening between the 24 to 28 week mark. And so that is the time that we need to screen people for gestational diabetes. However, if the woman told you that, oh, I had gestational diabetes in my earlier pregnancy, then this woman would have been screened at booking rather than at 24 to 28 weeks, because there's a risk of it happening again. And so either you're screening them at booking, or if they've not had a history of gestational diabetes, then you're screening them at 24 to 28 weeks. We know that most cases of diabetes is actually in the low and middle income countries, where Ghana falls. And as I explained, globally, GDM, it happens about 1 in 7 births. And in Ghana, we know that our rate is about 10% prevalence. So what happens in gestational diabetes that women develop diabetes because they are pregnant. We know that when women are pregnant, our insulin resistance goes down so that you can quickly transfer the sugar from your blood to the baby. So it's just a bit to get the sugar to the baby for the baby to grow. And so there's lowered insulin resistance. And this insulin resistance is lowered as a result of all these placental hormones that are produced, prolactin, estrogen, progesterone, all of these agents are all of these placental hormones increase your insulin resistance. We also know that in some women, there's actually insufficient insulin production, sort of what happens in type 1 diabetes. So they don't have enough, their body is not able to um, meet the increased demand for glucose in the pregnancy. So there's insufficient insulin production to meet the rising needs of the glucose levels. And then again, there's also a reduction in peripheral insulin sensitivity. We know that normally the muscles would take up the extra glucose and break it down and use it for energy. However, in pregnancy, there's a reduction in this peripheral insulin sensitivity. So all these factors would contribute to gestational diabetes developing. And again, can we have another quick poll? I mentioned earlier that we use the OGTT to screen the women. And what are the thresholds? If you can just put A, B, C, or D in your chat box, in the chat box for me. Is it fasting more than 1 hour, 11.1? So we've got all the options there. I just want to go to the chat box. Okay, so somebody said A. All right, can I have some more answers, please? Oops. Another person said A. Okay. Can I have 5 answers at the least, at the very least? Someone said C. Okay. Someone said A. So I have 1, 2, 3, 4, 5. Okay. All right. Thank you very much. So out of the 5 people, I think we've got more A's and 1 C. All right. Okay. All right. And actually, that is the purpose of this education that we are having here. We are all very familiar with the diagnostic thresholds for non-pregnant population. And actually, the thresholds for diagnosis in the non-pregnant population is very different from diagnosis in pregnant women. So what it means is that we are missing a lot of the pregnant women because we are not using the right criteria. Okay, and so let's go to the presentation and find out what the right answer is. So as I earlier explained, we'll typically do the OGTT around 24 to 28 weeks. And actually what happens is that it's not enough just asking the woman to go and eat and come back, or it's not enough asking, because when they eat, you don't really know how much carbohydrates they took. So this is a standardized test where women are given 75 grams of glucose. So would prepare the 75 grams, usually in about 250 to 300 ml of water. And first, what you do is you take a fasting blood sugar. So you'd advise the woman that, oh, eat your normal food in the preceding 3 days. On the eve of the test, make sure you eat by 8:10 p.m. and don't have anything else to eat apart from water. Avoid things that contain sugar like gum. Do not smoke, and visit the lab early in the morning. So early in the morning when they go, so you should have fasted at least between 8 to 10 hours. When you get to the lab in the morning, what they'll do is they would first take a fasting sample. Okay, and after the fasting sample is done, and remind you, this should be done with a venous sample, not glucometer. This should be done with a venous sample because the standardization of the test was done with venous sample. The mechanism for the venous sample is slightly different from how the readings are done with the glucometer. And so if you're using the glucometer, you're not doing it right. And actually, I found that actually a few of the labs use glucometer, and that is completely wrong. So if one of our lab people are here, please let's make sure that we are correct this. So first you take the fasted sample and then you give the woman the glucose drink and you ask them to kindly consume this within 5 minutes. Okay. So after 5 minutes, when they've consumed it all, then you time when they finish taking the drink 1 hour after that. So 1 hour after the sample is the glucose drink is consumed, you check blood glucose at the 1 hour mark. Okay, and then you would note it down, another venous sample. At the 2 hour mark, you take a third sample. So you have three samples altogether, fasting, 1 hour, and 2 hours. So the Americans do it slightly differently. They do a 3 hour OGTT, and instead of 75 grams, they use 100 grams of glucose. And so they will do a fasting sample, a 1 hour sample, a 2 hour sample, and a 3 hour sample. And their thresholds are slightly different. So we'll discuss that as the time goes on. Okay. So actually, the category for diagnosing is, if you look on your, let me get my marker. Okay. So let's look at the bottom here, the bottom left. That is what I've circled. This is what we follow in Ghana, which is the WHO population. So some of the countries don't screen everybody, which is called a universal screening. They do a selective screening. In the UK, they do that. They look at your risk factors. For instance, if you're Black, if you have a family history, if you're obese, if you've had previous GDM, then you'll be screened. Otherwise, you don't get screened. But actually, WHO currently recommends that all women should be screened because everyone here is Black. And okay, not everyone, but most people here are Black. And so we should automatically be screened because we said that there are ethnicities with a high prevalence. And so they are saying that you should look at your background population. And if you think that you have a high prevalence of it, then screen everybody. But like I said, because we are Black, because we have a high prevalence of diabetes, the recent guidelines, Ghana guidelines says that all women should be screened, not just selective screening. And that is, most people are not doing screening for all women. We're doing selective screening. So they might find a random blood glucose, which is high. And even the random blood glucose, which is high, look at the targets here. So fasting glucose should be 5.1. 1 hour should be 10 and 2 hours should be 8.5. Okay. So 5.1, 10, 8.5. So I want to go back to this threshold. So can we re-answer this question? Let's look at the targets here. So the number one is actually for diagnosis in non-pregnant adults. Okay, so if you've done an OGTT for somebody and you're using these targets, these are completely wrong. You can see that these targets are much, much higher than in the normal population, and that is not what we use in the pregnant women. And actually, when you send the patients to the lab and you just say OGTT, if you don't indicate that the woman is pregnant, these are the targets they are going to bring you. Okay, and you would say that you don't have diabetes, or your FVS is 5.1 or 5.3, so that's fine. But actually, that's not fine. So can we re-answer this question again? What are the OGTT thresholds? Can you put it in the chat box for me, please? This is remedial. Okay, thank you. All right, so I see D, 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 D now. Okay, so whenever a woman comes to you and is pregnant and you've asked that woman to do an OGTT, these are the targets that we should be looking at. Fasting more than 5.1 should be diagnosed as having GDM. 1 hour postprandial of 10 should be diagnosed as having GDM. 2 hour postprandial of 8.5 should be diagnosed as having GDM. So remember that the targets are much lower in pregnancy compared to women who are not pregnant. Okay, so this is what we follow here. In the UK, they do something slightly different. They just do a fasting and a 2 hour postprandial. They don't do the 1 hour postprandial. But because they don't do the 1 hour postprandial, they have lowered their 2 hour target from 8.5 to 7.8. So actually, anybody whose sugar is more than 7.8 is sugars are not completely normal, but we use the WHO and we use 8.5. As I explained, the Americans do something slightly different. So the Americans screen everybody, but not everybody does the 100-gram test. So they would first use a screening with 50 grams. So they first give you something containing 50 grams of sugar. And if your test result is high from that 50-gram test, then you proceed to go and do the 100-gram test. So they do what we call a two-step process. So if you can see a number of steps, WHO just does one step. The UK, they also do just one step. But in America, they do the 2 steps. So they'll do a first screening with 50 grams. And if you fail that 50-gram test, then you now go ahead and do the 100 grams. So whereas with WHO, only one value. So if your fasting is 5.1 and these two are normal, we will still diagnose you with GDM. If your fasting is normal and your 1-hour postprandial is high, we will still diagnose you with GDM. If your fasting and 1 hour is normal and your 2-hour postprandial is high, we'll still diagnose you with GDM. But in America, because they do the 3-4 test, you need 2 of these tests to be abnormal. So if you have only one abnormal test, you will not be diagnosed with GDM. You need 2. As I keep emphasizing, we follow WHO, and you need only one abnormal test. So remember, when you do the 1-step process, you need one abnormal test. Whereas if you do the 2-step process, then you need 2 abnormal tests. I hope that's clear. All right. So ideally, you've screened the person has screened positive. What's next? You're going to refer this person to the diabetes clinic, specifically designed for pregnant women if you have it, or if you don't have it, then you can refer to the general diabetes clinic. But remember that we have to make sure that we are getting the numbers right, because if you're not using these values, we're going to miss a lot of the women and we will not be referring them to the clinic. Okay. So you would send this patient to the clinic if their fasting was more than 5.1, if their postprandial 1 hour was more than 10, or if their 2-hour postprandial was more than 8.5. Again, so this is the pro forma we use at our hospital. And remember, I told you that there are some risk factors associated with diabetes in pregnancy. And so if a woman has not received screening, but somehow you find that they have polyhydramnios, they have macrosomia, or they have glycosuria, 2 classes or more, or if they have multiple pregnancies, this woman is at high risk of developing GDM. And so I would screen this patient also for GDM. So this is what the UK people do. Even if all these booking factors are negative, however, they've got glycosuria or macrosomia or polyhydramnios or multiple pregnancy, then this women would automatically be screened. But as I said, we follow WHO, and the Ghana guidelines say we should screen everybody. So actually, you don't even need to do these risk factors. Everybody who come in should be screened if they don't have pre-existing diabetes. And actually, when I was doing the presentation, I found this, which I thought was quite curious. We say that health, it's a factor of both what you do, what your country also does. So in India, as far back as 2007, the government actually issued instructions that they recommend universal screening and all women should be screened during pregnancy, and that is a mandatory test. So it was actually an order that all women should be screened. We have recently published the first guidelines in Ghana last year, and we also recommend that all women should be screened. 2024, we're a bit late to the party, but we're finally here. So remember that all women should be screened for gestational diabetes. So at the clinic, what happens? Ideally, you should have a multidisciplinary team with obstetric doctors, diabetes doctors who are well versed in the management of diabetes in pregnant women. You should also have dedicated diabetes midwives and nurses who are also keen to help support these patients. In addition, you need dietitians and diabetes educators, because remember that all of a sudden this woman didn't have diabetes and you tell her that she has diabetes. They need some sort of education to know what to do and explain to them what it entails. And hopefully a combination of these experts or specialists will provide comprehensive care right from preconception for the women with pre-existing diabetes or previous GDM, or for those who are diagnosed in the middle of the pregnancy. They'll be supported from then till their postpartum. And so what do you do as part of your patient education for the women with pre-existing diabetes? When they come, you want to talk to them about diets. We know that carbohydrates is what drives the glucose level. So you should explain to them what foods contain carbohydrates. You'd be surprised. I was actually speaking with a patient one time and I was like, do you know what carbohydrates are? She said, yes. I said, give me examples. And she said, oh, salad, cabbage. So I made it a point to make sure that the patient tells me what they know, because they'll say yes, but the answer they might give you might not be entirely appropriate. And so diet therapy here, hopefully you'd have a dietitian who is supporting the clinic, or even if you don't have a dietitian, these are basic things that you can explain to the patient that, oh, the food group called carbohydrates are what is going to drive your sugars. Don't tell the woman not to eat carbohydrates at all. That would be wrong. But then it would be to limit how much of the carbohydrates they have, and making sure that they are pairing the carbohydrates with foods that won't raise the sugar. So like our vegetables, our proteins, we know that proteins won't raise or spike your blood sugar. And so they shouldn't have foods that are only carbohydrate, but then making sure that they are mixing the foods. Okay. If diet, so for the women with GDM or type 2 diabetes, if diet alone is insufficient, then they will need pharmacological therapy, either with metformin or insulin. And obviously, if the patient has type 1 diabetes, then the only pharmacological medication which would be indicated in that case would be insulin. You'd also explain to the women what your glucose monitoring targets are, what your sugars, what numbers you expect them to find. Give me a second, please. Yeah, sorry. So you need to explain to the women what their glucose targets are. So I will come to that as well. And then as part of our antenatal management, they would need what we call fetal growth scans to monitor for things like polyhydramnios, monitor for macrosomia. So typically from 28 weeks, you'd institute a 4 weekly ultrasound scanning to monitor the fetal growth. And then at 36 weeks, you would want to plan delivery. So you have a discussion with the woman as to what to expect when they're in labor, what sort of delivery method they hope for. And you have all these discussions so that when the time comes, you've put together a plan in place and you know what you're doing. And after they deliver, what should they do? If they have type 1 diabetes, you need to tell them something. If they've had type 2 diabetes, you need to tell them something. If it was gestational diabetes, you need to tell them something. And so we'll go through that. As I have been stressing, the only medications approved for use is metformin and insulin. We used to give glibenclamide or glyburide back in the day, but most studies have shown that they're actually not very, it's most of the countries don't recommend it anymore. And actually in the US, they don't even recommend metformin at all. And so all women who have diabetes in pregnancy are put on only insulin. Here, our guidelines say we can give metformin and insulin. Glibenclamide probably not the safest thing to give in pregnancy. And with regards to our insulins, there are several different options. We have what we call the soluble or the rapid acting insulin. Soluble insulin is what we typically use on the wards for managing DKA, HHS, and you can actually use this as part of your regimen for women who are pregnant. You can also have the rapid acting insulin. So those are the analogs. An example is insulin aspart, or which is usually sold as NovoRapid. You can also give them intermediate acting insulin, so which is the NPH. What we typically have here is insulatard, or if you have the analog one, that's the Humulin I. You can use long-acting insulins like glargine, so which is typically called Lantus here. We've got Ditimir, etc. And I think everybody knows Mixtard. That is what we typically give here. But actually, it should be the last thing that we're giving to the pregnant women, giving them mixed insulins. You can, that's what we've been doing a lot, but current studies have shown that giving the separate insulins is better because it affords you that flexibility to be able to adjust the doses. So normally you'd start with like a long-acting insulin, so either NPH or glargine. And if that fails to control the sugars, you look at which meals are still causing the problem. So is it breakfast? Is it lunch? Is it dinner? And then you'd add either a soluble or rapid acting insulin at that point. So what we call the basal bolus or the basal plus regimen. That is what is recommended by most Western countries, but we do use mixed primarily. But I think that's also part of the education that we're doing so that we can, help change our practice with time. And so again, what are our targets for glucose monitoring? You can see that our targets are completely different for pregnant women compared to women who are not pregnant. Because for people who are not pregnant, we're looking at a fasting less than 7. But actually, if you are seeing fasting 7 in a pregnant woman, that is very high. you want a target of less than 5.3. 5.3. You want a 1 hour post meal. So you typically would monitor them 4 times a day. So they'll do a fasting, they'll do 1 hour post breakfast, 1 hour post lunch, 1 hour post dinner. Okay. And for all the post meals, you want their levels to be less than 7.8 if you're testing 1 hour later. If you're testing at the 2 hour points, then there's some variation depending on the authority. So the UK and WHO says 6.4, the Americans say 6.7. But actually, I think most guidelines say the 1 hour time because that's what everybody agrees on. And it's been found that actually using the 1 hour postprandial gives a more sensitive indicator of adverse fetal outcomes. So like macrosomia, large gestational age, it's been found that the 1 hour mark best approximates this. And so most people would screen using the 1 hour values. Also, it's been found that that is what approximates the post-meal glucose peak. So when you've eaten in pregnant women 1 hour, that's when they have the post and the peak of their glucose rise. And so that's the time that you want to test it. And people feel that testing at 1 hour also helps you to adjust your diet. Like I said, the benefits of giving the separate insulin, which is the rapid acting or the soluble insulin, is for the women to be able to adjust their doses depending on their blood glucose readings. Whereas if you give them a fixed dose of mixture, they can't really adjust their doses. And so for such women, if they monitor and their sugars are high, they can quickly adjust how much insulin they're going to give to themselves at the next meal. And so we think that the 1 hour point is the best thing to do. And some studies have also shown that this potentially reduces the need for insulin therapy. Because if the women are seeing that, oh, after 1 hour when I eat, my sugar is so high, they can actually make changes or adjustments to the diets that they are eating. So for part of our supportive care, so everybody needs dietary advice, everybody needs exercise, and simple things like, telling them to go for a 10 to 15-minute walk after they've had a meal really helps to bring down their glucose levels. And for some women, that is all that they might need to actually bring down their glucose levels. For most women with GDM, a lot of people are actually able to be managed on diet and exercise alone. So it's important that you tell the women these things and make sure that they're doing it. We know that DKA tends to happen in people with type 1 diabetes. However, pregnant women are actually also at increased risk of developing DKA, and particularly what we call the euglycemic DKA, where their glucose levels would be normal, but they would have high ketones. And we know that having high ketone levels is actually detrimental to the baby. A baby is at risk of death if you have lots of ketones. And so you should educate them about what to do when their glucose levels are high. Again, everybody you start on insulin should receive hypoglycemia education. So I saw a lady the last time who was recording sugars of 1.1, 2.2, 3. And she just kept recording without doing anything about it because she hadn't been taught that if your glucose levels is less than 4, this is what you need to do. And so make it a point that whenever you start a woman on insulin, also educate her that insulin is going to lower your blood glucose levels. We want it to go low, but not so low. If it goes below this, do A, B, C, D. Again, that was the patient I asked, what would you do when your glucose levels goes down? Because she's been told not to eat carbs, she said, oh, I'm going to have some salad. The salad is not going to reverse the hypo. So make sure that you're educating the woman and she knows exactly what to do. I earlier talked about fetal growth monitoring. So you do these scans 4 weekly from 28 weeks. So you normally do one at 28 weeks, you do another at 32 weeks, you do another at 36 weeks. And ideally, you should plot this on the fetal chart so that if the patient is crossing centiles or is dropping centiles, you can see. And that will help guide your management because that might be an indication for earlier delivery or for an intervention. And so doing a fetal growth monitoring, not just doing it, but actually plotting it on the graph really helps you to see if you need any intervention. And as I also said earlier, you need an intrapartum care plan. Usually by the 36-week appointment, you have a discussion with the woman what the delivery plan should be. All women with diabetes in pregnancy, i.e. gestational diabetes or diabetes and type pre-existing diabetes should have a planned birth. Okay, they shouldn't just show up at your hospital in labor. This birth should be planned, and you can discuss with them either they're gonna have induction of labor, spontaneous vaginal delivery, or cesarean section. And so you clearly document this. So for women who are managed just on diet and exercise, if they have no other obstetric indications, then the pregnancy can go as long as 41 weeks. These women should be delivered by the time they are 41 weeks. And so you document this clearly that, oh, if you don't go into labor prior to 41 weeks, then you need to come admission on so and so dates. Would we plan an induction of labor or would we plan a cesarean section? So you have that discussion with the women. So for women who are well controlled, either on metformin and insulin, then again, these women should be delivered by 40 weeks if they don't have any other obstetric indication. Okay, so again, you plan with her that, oh, if you don't go into labor by 40 weeks, or if we don't do your planned cesarean section by 40 weeks, then you should come on admission by so and so dates where would either do an induction of labor or a cesarean section. For women who are poorly controlled, who are on metformin and insulin, then you should deliver. So all this should be clearly documented. For women whose estimated fetal weight is more than 4 grams because of the risk of birth injuries such as shoulder dystocia and asphyxia, you should have a discussion with the women that ideally you should be delivered via cesarean section, and you document this clearly in your delivery plan. So this is a delivery plan that we use at our facility, which would fill and then put in the patient's note so that when they come, we know what dates they've been admitted, we know what we're going to do for them. Okay, so talking about postnatal care plans. So for people with type 1 and type 2 diabetes, as pregnancy goes on, we know that their insulin requirements gradually increase. So for instance, a type 1 patient might be on 10 units of insulin, like a total, I'm just using an example, a total daily dose of insulin of say 10 units at the beginning of the pregnancy. By the time they get to the end of the pregnancy, they could potentially be on 40 or 50 units because as the pregnancy progresses, insulin resistance also rises. So they need higher and higher doses of insulin. But as soon as the baby is delivered, that woman would not continue on that 50 milligrams, that 50 units. That's going to cause hypos. And so you should document what their pre-pregnancy insulin doses were, and then come to an agreement what you need to give them at the end of the pregnancy. You might need to reduce the dose, you might need to adjust the doses. And so you document this clearly in your postnatal plan. For women with GDM, remember we said that the GDM only happened because they were pregnant. And so as long as the pregnancy is over, that risk is no longer there. And so you'd completely stop all diabetic medications for them as soon as the placenta is delivered. As soon as the placenta is delivered, there's no reason why women with GDM should continue on the diabetic medication. So you'd stop this completely. But remember, having GDM actually increases your risk of type 2 diabetes. Remember the women who would develop GDM, they're the women who are obese, they're the women who are the risk factors for type 2 PCOS, they're the women who had hypertension. And so actually we know that about 50% of women would go on to deliver type 2 diabetes within 5 years of delivery. And so that's not the time you tell them that, oh, your GDM is over, the pregnancy is over, go home. You need to advise them. And what advice are you going to give? You should tell them that at 6 weeks, you should come back for us to do an OGTT to make sure that your sugar has completely gone back to normal. Either that, or at their 3-month visit, you should tell them to come to the hospital for an HbA1c to be done. I think it's easier to do the HbA1c. And so at 3 months, you tell them to come back, check the HbA1c, make sure that it's completely gone back to normal. And if it has, advise them that they are at increased risk of diabetes. And actually, they should be screened yearly for diabetes because there's that risk which would continue throughout their lifetime. And so communicate that to them that you have a risk. Don't say the pregnancy is over, the diabetes is over, bye-bye, we will not see you again. Communicate that risk that you have a lifetime risk. So make sure you're careful with your diet, make sure you're exercising. If you're obese, try and lose weight, etc., etc. And document if it has resolved. For some women, because they are only getting into contact with the healthcare facility because they were pregnant, actually they might have had pre-existing diabetes, or they may have had an increased risk. So document whether it's resolved, or if not, then they have type 2 diabetes, and then you manage them as such. So after the pregnancy is over, advise them about contraception. Make sure they've chosen a contraceptive method, and advise women who have had GDM that at your next pregnancy, don't just show up pregnant. Let us know if you're planning pregnancy. And if you do get pregnant unknowingly, quickly come to the hospital because this time we need to do your glucose testing earlier than the 24 to 28 weeks. And same for the type 2, type 1s. Tell them, don't just show up at the clinic pregnant. Next time, come, let us plan. So there's preconception planning. Make sure that you optimize everything before they embark on a pregnancy. And obviously, if someone has type 1 or type 2 diabetes, then they need to be followed up at the diabetes clinic. So then refer them back to the regular adults diabetes clinic. So I've talked about contraception and pregnancy planning. So what about the babies? When the babies are born, ideally they should be reviewed by a pediatrician, because we know that babies who are born to women with diabetes are at increased risk of hypoglycemia. And so you should feed these babies within 1 hour. And we say that breast is best. So advise the mother, if she'd like to breastfeed, then these babies should be fed as soon as they are born, and definitely not later than 1 hour. If for any reason they cannot be breastfed, then they might have to be fed artificially. And you want to do 2 pre-feed glucose readings, and you make sure that the numbers are more than 2.6 to be happy that their sugars are fine. So if you document 2 consecutive feeds, typically the second and the third feed more than 2.6, then you say that they are stable. And you should monitor these patients at least for 24 hours before you discharge them home. I know that normally when people have regular deliveries, usually within 4 to 6 hours, they are sent home. But women with diabetes shouldn't be discharged home until at least their babies are 24 hours old. For people who had pre-existing diabetes, that is if they had type 1 or type 2, depending on what their pre-pregnancy HbA1c, because you can have a woman coming with an HbA1c of say 10% who's pregnant. That baby is at increased rates of developing complications, fetal anomalies. So make sure that they are screened if the babies are born to such mothers. And so I'll go back again. What are the problems if you don't monitor and treat diabetes well? In the early pregnancy, you can have lots of spontaneous miscarriages. In the late pregnancy, you can have lots of intrauterine fetal death. So you have lots of unexplained intrauterine fetal death, and you don't know why. It's just because the sugars are so high and they're not being managed well. In the pregnancy, they're at risk of developing PE, gestational hypertension, and preeclampsia. That is why in women who have pre-existing diabetes, we give them aspirin, 150 milligrams till after the end of the trimester, till the 36 weeks, and then you stop. So these women should be advised. Delivery, they're at risk of birth trauma. So if the baby is big, they could have lots of typically shoulder dystocia, or they could even have a maternal mortality. There was a case where the woman developed sepsis post-delivery from poorly controlled blood glucose levels. So this is potentially a life-threatening condition which should be managed with all the seriousness that it deserves. And for the women who do not have GDM, who just had GDM, remember, as I said, increased weight, increased risk of GDM in the next pregnancy, increased risk of type 2 diabetes, increased risk of cardiovascular death. Actually, there's been a study that showed that even women who do not develop type 2 diabetes post GDM still have a higher risk of CVD disease compared to women who did not have. And so don't just tell them that, oh, it's gone, go and live your life. Advise them that they need to be careful about how they live their lives. The fetal complications, again, we could have stillbirths, you could have neonatal deaths, you could have congenital malformations in people's whose sugars are poorly controlled prior to the onset of the pregnancy. I talked about the birth trauma, and there's the risk of hypoglycemia. And so, what is my take home message? Can we please put in the chat box what the diagnostic criteria for GDM is one more time? So, tell me what the diagnostic criteria is, and tell me what the glucose monitoring targets are. And remember that these targets are lower in difference for pregnant women compared with adults who are not pregnant. So, can you put in the chat box for me? First, let's write the diagnostic values, and second, let's write the glucose targets. Can I have at least 2 people typing? And remember that managing these patients should be done in a multidisciplinary team who are well experienced in the management of diabetes. So after all, we know that teamwork makes the dream work. Okay, so I'll end by saying that remember that if you don't, there's a proverb in Chi that says that if you don't go digging into the eyes of if you go digging into the eyes of a dead person, you will find a ghost. Okay, so it's the same with gestational diabetes. If we look for it, we will find it. But if you don't look for it, then you will not find it. Okay, so again, if we screen for people with diabetes at the booking pregnancy, then we'll be able to pick up the patients who have diabetes. And so let us constantly remember to screen both at booking, and for those who screen negative at booking, to screen them for GDM between the 24 to 28 week period. Thank you very much for listening. And if you have any questions, here's my email. You can contact me if you have any questions or clarification. And these are the references that I used. Thank you.
Thank you so much, Dr. Morgan. That was excellent, fantastic. We learned a lot. I think there are a couple of answers to the question that you post in the chat box if you would want to take a look.
Okay, let's see. So somebody says, at what gestation do you screen clients for gestational diabetes? So I think I've hammered it over and over again that you'd screen them. If they have a previous GDM, then you screen at booking, okay? And if they don't have previous GDM, then you screen at between 24 to 28 weeks with 75 grams OGTT.
Great. So just before we take questions from people, I want to highlight that in the chat box, I've put in a message there. If you can go back there with me, and maybe those who have just joined, I'll re-put it in. A couple of people usually ask for the webinar recording and the PowerPoint presentation slides. So I've just put it in there. What to do to get it? Subscribe to our YouTube handle. You'll find those details there, both the webinar recording and the PPT slides. So for this one, I'll take from Dr. Morgan and upload as well. We are on all social media handles, Facebook, LinkedIn, and we have a WhatsApp channel as well. The details are right in the chat box. So you can go ahead and then follow any of those links to join us on all those platforms. As well, if you want the slides and webinar recording, maybe your network was terrible or you joined in late, you can have all of that at the comfort of your home anytime you want it. So we will take questions from you. If you have any, kindly electronically put up your hand and then I will mute you so that you can go ahead with your question. In the chat box, I see Rita Sefa has says, great presentation. I can't agree any less with you, Rita. This has been fantastic. So she's thanking you, Dr. Morgan, for an excellent presentation. Guys, if you have any questions, don't feel shy. Just electronically raise up your hand and I'm happy to unmute you to go ahead. Yeah, so Muniratu is up. Kindly go ahead with your question or comment. Thank you.
Okay. Thank you, doctor. Great presentation. Yeah, I have a question about the insulin management of gestational diabetes for the pregnant women. Actually, our settings is the metformin and glibenclamide that they normally order. So I want to find out if I happen to have the insulin there, is there a scale value, insulin scale values for me to follow or for me to know before I give the insulin, normally the soluble one, to the pregnant woman? Thank you.
Okay, so I think that before you manage anybody, you should ideally be well trained so that you know exactly what you're doing. Typically we would start with metformin, okay, and maximum dose of metformin is 2 grams. So you've given this patient dietary advice, you've given this patient exercise advice, the patient is doing all that, and you've given metformin 2 grams. You've maxed out on how much metformin you're given. Sugars are still high. At that point, you need to consider giving insulin. And you need to look at the glucose readings to see which numbers are elevated to decide which ones to give. Typically, we'll start with the basal insulin. So either Insulatard or Lantus. but I can't tell you the exact numbers if I don't see what the glucose readings are, and then also the patient's weight. So I think that such a patient should probably refer to the diabetes clinic, who I hope would be well trained in how to manage the patient. You can't use soluble insulin alone. You can give soluble insulin prandially, i.e., before breakfast, before lunch, before dinner. That's if they have isolated raised glucose levels post meals. However, if the patient, for instance, has elevated fasting glucose, then giving him or her soluble insulin would not be the way to go. In that case, the patient probably needs a basal insulin at bedtime. And so I think you should refer to somebody who is well versed in the management of such patients to be able to help you.
Great. Thank you, Dr. Morgan. Anita, you are up with your hands. Kindly go ahead, unmute yourself, and then you can make your contribution. Anita Sarik.
Thank you, sir. Please, my question is, there was this woman who was attending antenatal at least. Then I referred her to do they said that she was diagnosed with pregnancy-induced diabetes. So she was kept on this metformin. But every time she complained of vomiting and body weakness. So I referred her back to the hospital. She went and they asked her to continue taking the metformin. According to the client, when I asked her, she said she has been taking. Not knowing she wasn't taking because of the vomiting and then the general body weakness. So after she delivered that, she was now telling me that when she was experiencing that she wasn't taking the medication. So I don't know if there was something they could do rather than asking her to continue taking the metformin, which was causing her the vomiting and then the general body weakness. Thank you.
Okay, thank you very much. I didn't hear you properly, but I think you were saying that someone was given metformin and was intolerant. And so are there other options? Is that the question, Dominic?
Yes, it is.
Okay, all right. So as I earlier explained, medications that we use for GDM and type 2 diabetes is they are metformin and insulin. And like she rightly said, all medications have got side effects. And unfortunately, with metformin, one of them would be diarrhea, vomiting, abdominal pain. And so I think it's the same principle. If you give a patient a medication and they are intolerant, there's no point asking them to continue. And so you would discontinue the medication. But at that point, what option remains? It would be insulin. And so you would have a chat with the patient or the lady that since you cannot tolerate the metformin, insulin is what we would give you. And as I said, actually in the US, they don't give metformin at all. Their guideline recommended medication is only insulin.
Great. Thank you, Dr. Morgan. Next is Dr. Opong. Dr. Opong, I've asked you to unmute yourself. Go ahead.
I missed the entire presentation because I was busy with other things. But I have a question concerning pregnancy, diabetes in pregnancy, and the question is, at which month can you diagnose somebody with gestational diabetes? Which period of pregnancy can you diagnose someone with gestational diabetes? And then I want to know the value at which you can say after OGTT somebody can be diagnosed with diabetes.
Okay, thank you very much. Whilst I'm answering the question, can I please have somebody answer his second part? He wants to know what are the diagnostic ranges. So can someone please put it in the chat box? But I said earlier, true gestational diabetes only happens in the pregnancy, typically happens from the 24th week. And so you would screen this person at 24 to 28 weeks. If you diagnose somebody earlier, it could be that the person had pre-existing diabetes, or there's this thing that we just say diabetes in pregnancy, because we can't really tell whether this diabetes was there prior to the pregnancy, assuming she makes screening at booking. So remember I said that everybody should be screened at booking. That way we can pick up those who have diabetes but have not been diagnosed. Okay, if you miss this screening and you pick it up at any other point, then it's a bit difficult to tell if you're picking it up around the 24 to 28 weeks. Could it be that this person had diabetes all along, but because we didn't screen, we didn't find it? Remember my proverb that if you don't look for it, you won't find it. And so if you screened earlier and that was negative, then through gestational diabetes, the screening would happen between the 24 to 28 weeks months. And I see somebody has asked in the chat box, so between 24 to 28 weeks. The diagnostic values: fasting 75 grams OGTT, fasting less than 5.1, 1 hour post glucose drink 10, 2 hours less than 8.5. So those are our diagnostic ranges that you'd use for the diagnosis in pregnancy. And as I keep saying, remember, they are very different from non-pregnant adults. And so if you send a patient to do an OGTT and they come back, they might likely come with the results that they would give to non-pregnant people. So make sure that you're looking at the numbers yourself and not just relying on the interpretation that the lab has given. Look at the numbers yourself, and the numbers you're looking for: 5.1, 10, 8.5.
Excellent. Dr. Pong, do you have any further? I see your microphone is still unmuted. Okay, so it's gone. Yeah, so just to draw the attention of Dr. Pong and all those who joined in late, that this webinar is being recorded, like you've seen, and it will be put on our YouTube channel. So if you join in late and you want to have a review of it from the start, you can have that done when we upload it. So just go to our YouTube channel, like I've put the link in the chat box. I can put it again for those who have just joined, and then you have all of those details. Anyone else, any hand up? Kindly, if you have any question, comment, contribution, please put up your hand and I'll be glad to unmute you to talk to Dr. Morgan. Dr. Fred, please go ahead and unmute yourself.
Good afternoon. Thank you so much, Dr. Morgan, for the presentation. Mine has to do with the timing for delivery. You mentioned if they are stable on diet and exercise, they can go all the way to 41 weeks. I'm not sure I've come across that before. Typically, the teaching has been to deliver them by 39 weeks. So I'm a bit confused right now. So if you can help clarify that, thank you.
Okay. Yeah, I think that at first we used to say everybody should be delivered early, but now the thinking has changed a little bit. So your delivery plan should be dependent on how well the patient is doing. So if they are on diet and they are on no medication, the current teaching is that you should deliver by 41 weeks, not at 41 weeks, by 41 weeks. So if you have any obstetric reason why they should be delivered early, then obviously you need to deliver them early. But these are the current guidelines. The thinking has changed from delivering everybody by 30 completed weeks to really looking at how the glucose levels have been.
Great. Your hand, electronically raise up your hand. I'll be happy to unmute you. I see that one of our legendary bosses, Dr. Naganda, was the one who put in the answer to the question on the gestational diabetes. Dr. Gandao, we salute you. He's been a game changer for the Upper West. Get a lot of doctors in there, including myself.
Thank you, sir, for your service.
Dr. Pong, I see your hand is up again. Please go ahead.
Yes. Boss, I would like to know the kind of advice a practitioner or a physician should give regarding breastfeeding and future risk of type 2 diabetes after a patient has been diagnosed with gestational diabetes.
Okay. I think the mantra has always been that breast is best, isn't it? So if there is no contraindication why somebody cannot breastfeed, then you should encourage the women to breastfeed. And actually, for people with type 1 and type 2 diabetes, we know that breastfeeding actually helps to lower the blood glucose levels, as well as being cardio CVD protective. And so we encourage everybody to breastfeed if they can, if there's no reason why they can't breastfeed. And the baby should ideally be fed within the first hour of delivery or within the first hour of birth. With regards to the advice, as I kept saying, don't ever tell anybody with GDM that the pregnancy is over, the diabetes is over, go home and sleep. Okay. You'd be doing the woman a disservice. Tell her that since you've had GDM, you have a lifetime risk of developing type 2 diabetes. And actually, 50% of women would go on to develop type 2 diabetes if nothing changes, i.e., if she's obese or overweight and she's not able to lose weight, if she continues to eat what should I say? If she continues to eat foods which are not like healthy, if she continues not to exercise, i.e., if the risk factors that predispose them to getting the GDM are still present, then they would still have the risk factors for developing type 2 diabetes. And so I would say, because you have an increased risk, make sure you're keeping an eye on your sugars. At least get a yearly screening, and depending on how the numbers are, that can help determine what the future would be. But for instance, in the UK, they have decided that everybody who develops GDM should have yearly screening, HbA1c screening for a lifetime, so that they can pick it up early. So we can, as Dr. Gandal said, some of these things, we need national policy direction to, guide how patients are managed and to guide our practice. So you can advise the woman to maybe check your sugars every year or every 2 years. And obviously, if you're checking and the HbA1cs are higher and higher, then obviously you need to reduce, the time for the screening. And so don't tell them you've had GDM, that is it, bye-bye. But let them know that they have an increased risk. And as I said, even in women who don't develop type 2 diabetes, there is an increased CVD risk because they've had GDM in the past, and so let them know that that's the unfortunate fact.
Great. Dr. Salam, please go ahead with your question.
Thank you very much, Doc, for the insightful presentation. I actually joined late, just following the Q&A session. But I just need a bit of clarity on the delivery extending to 41 weeks. Is it for those who are on only diet and exercise with good control, or if even the patient is on medication such as metformin and insulin, you still have to extend to 41 once the control is good? And secondly, most of the time you realize that the GDM or diabetes in pregnancy generally is comorbid with hypertensive disorder. In such cases too, how do we marry or how do we decide when to deliver? Thank you.
Okay. So I've just put it up again. So again, the first one is for women who are on diet and exercise, aim to deliver by 41 weeks. So you can deliver anytime between 39 to 41 weeks, but make sure that they've had their baby by 41 weeks. For people on metformin and insulin whose sugars are well controlled, then you can aim to end their pregnancies from the 39th week to 39 plus 6. And for people who are poorly controlled, then you need to aim to deliver by 39 weeks. So we've moved away from the blanket deliver everybody by. You need to look at each patient individually and then come up with a delivery plan. Yes, so for type 1 and type 2, I said that preeclampsia coexists. It's one of the complications. So these women receive prophylactic aspirin at the end of the trimester, at the end of the first trimester till the beginning of the third trimester. You actively screen for urine proteins at each visit. You'd actively check their blood pressures, and if they are high, you should manage those as well, because they, like you said, they tend to run hand in hand.
Great. Any more question, comment? Kindly put up your hand and I'll be happy to unmute you. Yes, Dr. Salam, is it a legacy hand or is it a new one?
No, it's just a follow-up. I mean, as I said, I didn't join earlier, and rightfully, as she mentioned, that was the criteria. But also, just to get some clarity too on the issue of the aspirin. When do we stop the aspirin? Because I think I heard something like beginning of third trimester. I want to get some clarity on that.
So by 36 weeks. You
Okay.
start from 13 weeks to 36.
Isn't it till
Not
delivery?
No. So you start, that's for type 1, and you start at the end of the first trimester. So that'll be 13 weeks till 36 weeks.
All right. Okay. Thank you.
Okay.
All right, great. I think Dr. Obong has his hand up again. Go ahead, Dr. Obong.
Yes, Dr. Morgan, I want to find out this. A patient present to you with type 1 diabetes and currently pregnant. And now he comes to you, he has pre-existing type 1 diabetes, who gets pregnant and comes to you with DKA. How would you go about her management?
I think that with DK, you can use the same protocol that you use in the management of adult patients with diabetes, which would be to give your fluids, give insulin, give electrolytes, which is the potassium replacement. So if you have an institutional protocol for DKA at your place, it's the same management. The only thing is that with pregnant women, as I said, they tend to develop euglycemic decay, and so their glucose levels may actually be normal, but their venous pH or bicarb levels may be low, and they might have ketonemia or ketonuria. And so you can still use the same protocol. If someone has euglycemic decay, the only difference in the management would be instead of giving normal saline, you can start with dextrosaline, 5% dextrosaline, so that you can continue to give your insulin, because the insulin is what is going to clear the ketones that are in the blood. Nowadays, we moved away from Albertis. We tend to use IV insulin with IV fluids with the electrolyte. And so I don't know if that's what you do at your facility, with ideally via a perfuser or a dorsiflow.
Albertis in all
The
its
management.
forms. Whether it's
Sorry.
modified Albertis in all its forms.
Well, so again, for most of the Western countries, they don't do subcutaneous insulin. Most patients would receive IV insulin because when they come, they're profoundly dehydrated, and the absorption of insulin is not very good with the subcutaneous route. But if for any reason you don't have perfusers or dorsiflows, then you can use, I think it's best to use whatever protocol that you use at your facility, because that's what everybody will be used to. So use the protocol that you use at your facility that everyone is familiar with. But the management is not any different. The difference would be that when their glucose, if they come with euglycemic decay, then make sure you're giving them dextrosaline at the outset rather than normal saline.
Absolutely. I was just probably seeing the funny side of it, where there are perfusers, but most people probably because of not being used to it or not being taught how to correctly use it, still keep to subcutaneous insulin, which doesn't really help a lot. Yeah. So I see Ruth's hand is up. Please go ahead, Ruth, and make your contribution.
Okay, hello, thank you. Good and a good afternoon to everybody. So I heard you mention that the 1 hour postprandial figures are better for monitoring. Most institutions, okay, well, at least the ones I've been privy to, usually do more of the 2 hour postprandial for monitoring with a glucose profile. So are you suggesting that we shift to the 1 hour postprandial for monitoring? Thank you.
Yeah, I think most of the places from where we all received our training was usually the 2 hour postprandial, which is the same that was being done at my facility. But since setting up the clinic, we have moved away from doing 2 hour postprandial to 1 hour postprandial. And medicine is dynamic and things are constantly changing. And so when new evidence becomes available, I think it behoves on us as clinicians to also change our practice. And so at my facility currently, we use the 1 hour postprandial rather than 2 hour postprandial. But maybe we need the obstetric team to maybe come up with specific guidelines just for diabetes. The first diabetes guidelines in Ghana was just recently published last year. So hopefully with time we will be having our own protocols and changing how we do things. It's just like the OGTT. So actually I went to one of the facilities and their OGTT, they're checking the sugars every 30 minutes for 2 hours. So then I said, what's the point in doing 30 minutes when all that we need is the fasting 1 hour and 2 hour values? I think because we've been used to doing it that way, people tend to hold on to doing things how it's been done. But as I keep stressing, as new evidence becomes available, we should make sure that we're doing what is up to date.
Great. I like the last part. What is up to date? Any more questions? Ruth, I see your hand is still up. Do you want to make a follow-up? Please go ahead.
Okay, so yeah, I was just for clarity, wanted to find out. So are we using the 7.8 now to use to monitor the 1 hour postprandial?
Yes, I think all the guidelines agree on the 7.8 at 1 hour. Where it differs is the 2 hours. Some people say 6.7, some people say 6.4. So which one do you use? So I think the 7.8, everybody agrees to that. It's the same with the fasting 5.3, everybody agrees to that. And so most places now, they're all using the 7.8 at the 1 hour mark and 5.3 at the fasting point.
Yeah, fantastic. Dr. Salam, please go ahead with your contribution.
I mean, sorry for coming back again on this issue, but it's still on the aspirin. I mean, as a student, boss, I hope you grant, but just check, because I know that for aspirin, it's usually to delivery. That's according to the ACOG 2018. So I don't know whether there is something latest to that recommend we should stop at 36 weeks. And I'll be glad to have the guideline, which is suggesting we should stop at 36. Thank you.
Okay, so again, I think different countries do different things. So in the UK, where they follow the NICE guidelines, they don't continue till delivery. They would usually stop at the 36. You can just look up the NICE guidelines and they do 36. It's possible that ACOG recommends till delivery, but again, it depends on where you trained or your facility and what protocol that you're using at your institution.
Fantastic. Hopefully, like you rightly said, when we begin to develop our own guidelines for everything, we won't have to look towards the colonial masters or towards the North Americans for their guidelines. And students and residents like Salam will have to have different figures for a membership exam when you are called upon. If we have our own local guidelines, we know what's best for us and what works for our people. But of course, it's through advocacy and programs like this that we get to have people join us, like Dr. Gandao and those who are more into policy, and then we're able to influence the change. So it starts with all of us. Let's make it a point to recommend and usually advocate for us to do our own studies to have such guidelines. Thanks, Anuva. Any more questions? I just take one or two, and then we can close the session for today. Any other question, kindly electronically put up your hand and I'll be happy to unmute yourself.
Okay, so I just wanted to highlight this to the doctor who asked about the aspirin. So this is the UK guidelines, and they say, I hope you can see the screen. Advise pregnant women with pre-existing diabetes to take 150 milligrams of aspirin from 12 weeks until 36 weeks. So that's what the NICE guideline says, but it's possible the ACOG guideline is different from what NICE recommends. Okay. Hi, Dominic, are you still there? I can't seem to hear anything.
Yeah, I don't see any hand up. I see a contribution, some few contributions from the chat box. So there's one from Sarah. Says, thank you, Doc. The DM should be added to the routine service for all pregnant women across the board. Thank you. And Dr. Gandao posts, aspirin is to ensure the uteroplacental circulation to prevent the IUFD and IUGR by 36 weeks. A lot is achieved. By 36 weeks, a lot is achieved. We don't have the 150 milligram in Ghana. And Jennifer
Actually, they don't have 150 milligrams or so. They were given 275 milligram tablets.
Of the 75. Okay, all right, great. Yeah, Dr. Morgan, go ahead.
Yeah, I was saying
Hello?
that in the UK, they don't have
Hello?
150 milligram tablets as well. They were using 275 milligrams. But I think as Dr. Gandao said, and as you've said, when we develop our own guidelines, then we can decide what's best for us. But other than that, we just use, guidelines from various places, which sometimes have conflicts.
Fantastic. Then Jennifer puts in, Dr. Morgan, can I be heard?
Yes,
Hello?
we can hear you. I
All
can
right,
hear
great.
you at least.
So Jennifer puts in, how will we ensure that the screening is done at the health centers and the CHIPS compounds? Because they do a lot. I think it still comes to about the policies and ensuring that those are implemented. What's in the books, like Dr. Morgan mentioned, obviously, at booking, you are required to check a couple of that. And so these are things that we should contribute from our own end towards ensuring them, rather than just allowing them to be blunt or blank and not check. It's important to have these done. So thanks, Jennifer, for your contribution. I think we've gone way beyond the hour mark. I would wish to draw the curtains down on today's presentation, and I want to, on behalf of Ghana Medical Health and all of you, thank Dr. Morgan for an excellent job done, taking us through the updated guidelines on diabetes and pregnancy. And for all of you who have joined us today, we are grateful. We'll come your way again next week, and hopefully on a different topic. Kindly look out on our social media handles, like I've put up on the chat, in the chat box, and then you'll be able to see the upcoming topic as well. The recordings, like I mentioned, for today's webinar and all the other webinars will be put on the YouTube page. Like you just see in the chat box, you can click on any of those links and you have all of that to your comfort. Thank you so much, Dr. Morgan. Thank you all for joining us for today. God bless all of us and take care. Bye-bye.
Bye. Thank you for the opportunity to come your way today.